Welcome back to SurgiSmart Cut to the Core podcast, where we break down essential surgical topics to help you understand surgical conditions. I'm your host, Major Munish Chauhan, and I am a General Surgery Registrar in the British Army and at Oxford Deanery. I'm also a Senior Research Fellow at the Center for Army Leadership. Feel free to connect with me on LinkedIn if you have any questions or interest in these topics. So in this deep dive, we're going to be looking at esophageal motility disorders. This is a really essential topic for any surgical trainee, but particularly those preparing for the FRCS exam. We're going to cover three key conditions today. So we're going to start with achalasia, then we'll look at diffuse esophageal spasm and hypercontractile esophagus. And finally, we'll end with Scleroderma-related esophageal dysmotility. By the end of this deep dive, you'll have a really solid grasp of how these conditions actually affect the esophagus, how they're diagnosed, and the latest in how we manage them. So let's start by tackling achalasia. It's really interesting how a simple analogy can help us visualize what's happening in this condition.
So imagine you're trying to enjoy a thick milkshake, but the straw keeps collapsing. And that's very similar to what happens in achalasia. The lower esophageal sphincter, or LOS, which acts like a valve at the bottom of the esophagus, it fails to relax. And the esophagus itself struggles to squeeze food down, a process we call peristalsis. But this isn't just about a faulty valve, it's a neurological issue as well. There's degeneration of inhibitory neurons in the myenteric plexus, and this leads to an imbalance in the signals that actually control the esophagus. And here's where it gets even more intriguing. Achalasia has different subtypes, type I, type 2, and type 3, and each with its own kind of quirks. So type I is like a completely limp straw, no squeezing at all. Type 2, though, is a bit of a paradox. Despite squeezing all over the place, it often responds well to treatment. And then there's type 3, the most troublesome, with spasms and pain, almost like the straw is having a mind of its own. Now, how do we make sense of all this and diagnose the specific type of achalasia? Well, we have our trusty toolkit. So we've got the barium swallow, high-resolution manometry, or HRM, and upper GI endoscopy.
The barium swallow, where the patient drinks a special liquid that shows up on x-rays, lets us see the esophagus in action. In achalasia, it reveals this classic bird beak narrowing at the gastroesophageal junction, or GOJ. Then there's HRM. This is the gold standard for diagnosis. This involves a thin tube with pressure sensors, and this gives us a detailed pressure map of the esophagus. And lastly, upper GI endoscopy, where a thin flexible tube with a camera is inserted, allows us to visually inspect the esophagus and rule out any other conditions that might mimic achalasia. Okay, so we've diagnosed achalasia, now what? Well, the goal of management is pretty straightforward. Reduce that LOS pressure like unclogging our milkshake straw. We have several options, each with its own set of pros and cons. And deciding on the best approach involves carefully considering the individual patient. So one option is the Heller myotomy. This is a minimally invasive surgery where the surgeon cuts the muscle fibers of the LOS to reduce the pressure. It's a highly effective procedure, but as with any surgery, there are inherent risks involved. Then there's pneumatic dilation.
This is an endoscopic procedure where a balloon is inflated at the LOS to stretch and disrupt the muscle. This is less invasive than surgery, but it carries the risk of perforation. And in recent years, we've seen the emergence of per-oral endoscopic myotomy, or POEM. This is a newer endoscopic technique where the surgeon actually creates a tunnel within the esophageal wall to access and cut the LOS muscle. It's showing promising results with minimal invasiveness, making it a potential game changer in the field. Now, for patients who might be high risk for surgery or endoscopy, we have the option of botulinum toxin injection. This temporarily paralyzes the LOS muscle, providing relief, though it does require repeat injections as the effect wears off. And for short-term relief, we can use pharmacological therapy. Medications like nitrates or calcium channel blockers, which can help relax the esophagus. But here's a thought to consider. What factors would you as a surgeon prioritize when choosing between these treatment options? Would the patient's age and overall health play a role? What about the severity of their symptoms or the specific subtype of achalasia they have? These are just some of the things we grapple with in the real world of surgical practice. So let's shift gears now and talk about diffuse esophageal spasm, or DOS, and its close relative hypercontractile esophagus. Remember our milkshake straw? Well, in DOS, it's like the straw is having a seizure with uncoordinated contractions all over the place. This can cause dysphagia or difficulty swallowing and often chest pain. It's a real esophageal roller coaster, but not the fun kind. Hypercontractile esophagus, on the other hand, is like the straw squeezing with superhuman strength, propelling the milkshake out the other end with incredible force. Here, the contractions are excessively strong, but at least they're coordinated. So how do we tell these two conditions apart? Once again, HRM is our hero, providing a detailed pressure map of the esophagus and revealing the distinctive patterns of each condition. In DOS, the HRM will show these simultaneous chaotic contractions throughout the esophagus while the LOS relaxes normally. In hypercontractile esophagus, we'll see extremely high pressure waves, a signature sign of those powerful squeezes. The barium swallow can also give us clues. In severe cases of DOS, it might show a corkscrew appearance of the esophagus, highlighting those abnormal contractions. And of course, endoscopy is crucial for ruling out any other structural abnormalities that might be causing the symptoms. And you might be thinking, okay, these conditions sound pretty similar. How do we approach their management? Well, that's a great question, and it highlights a crucial point. While both DOS and hypercontractile esophagus involve abnormal esophageal contractions, they require a nuanced approach to management. The primary focus in both cases is on controlling those troublesome symptoms and improving the patient's quality of life. Lifestyle modifications play a key role here. Think about it. Avoiding triggers like hot or cold drinks, large meals, and even stress can significantly impact how the esophagus behaves. Pharmacological therapy is another important tool in our arsenal. Calcium channel blockers and nitrates can help relax the esophageal muscles, easing those spasms. Tricyclic antidepressants can be helpful in managing the pain that often accompanies these conditions.
And for those stubborn hypercontractile segments that just won't quit, botulinum toxin injection can provide targeted relief, relaxing those specific areas. Now, in some cases, these measures might not be enough, and we might need to consider endoscopic or surgical interventions. Myotomy, for example, where the surgeon cuts the muscle fibers to reduce pressure, can be an option. POEM, which we discussed earlier, is also showing promise as a minimally invasive approach for these conditions. So we've covered a lot of ground on DOS and hypercontractile esophagus, but here's something to ponder. Imagine you're presented with a patient experiencing dysphagia and chest pain. How would you go about differentiating between these two conditions? What specific questions would you ask? What investigations would you order? And how would you explain these complex conditions to the patient in a way that's both informative and reassuring? This is the kind of clinical reasoning and communication skills that are essential for any aspiring surgeon. Now let's move on to our final esophageal disorder for today. Scleroderma-related esophageal dysmotility.
This one's a bit different, and it highlights the interconnectedness of various systems in the body. You see, scleroderma-related esophageal dysmotility isn't a primary esophageal issue, but rather a consequence of systemic sclerosis, an autoimmune disease that affects connective tissues throughout the body. It's a classic example of how a systemic illness can have significant implications for a specific organ. In scleroderma, the body's immune system essentially turns against itself, attacking its own tissues. Unfortunately, the esophagus often gets caught in this crossfire, leading to atrophy and fibrosis or scarring of the smooth muscle. Imagine the esophagus turning into a stiff, poorly functioning tube, struggling to do its job. As a result, we see severe hypomotility. The esophagus loses its ability to contract effectively, leading to difficulty swallowing and food getting stuck. To make matters worse, the LOS becomes incompetent, failing to keep stomach acid from splashing back up into the esophagus. This reflex can cause a whole cascade of problems, from heartburn and regurgitation to more serious complications like aspiration, where food or liquid enters the airways. So how do we diagnose this complex condition? Well, our trusty trio of investigations comes into play once again, each providing a different piece of the puzzle. HRM reveals the telltale signs of absent peristalsis and a hypotensive LOS, confirming the sluggish movement of food in the weakened valve. The barium swallow shows dilation of the esophagus and delayed clearance, further supporting our suspicions. And endoscopy allows us to assess the extent of mucosal damage caused by reflux, which can range from mild inflammation to more serious issues like Barrett's esophagus or strictures. Now, you might be wondering, okay, this condition seems pretty challenging to manage. What options do we have? Well, you're right, it is challenging, and the management of scleroderma-related esophageal dysmotility requires a multifaceted approach. The focus is on two key areas: controlling reflux and providing supportive care. Reflux control is paramount here. High-dose proton pump inhibitors, or PPIs, are the first line of defense, helping to neutralize stomach acid and protect the esophageal lining. Prokinetic agents can also be used to enhance esophageal clearance, essentially helping to sweep away any lingering acid. Lifestyle modifications also play a crucial role. Elevating the head of the bed and avoiding late meals can make a significant difference in reducing reflux. And in some cases, surgical options like fundoplication, where the top of the stomach is wrapped around the lower esophagus to strengthen the valve, might be considered. However, it's important to note that the results of surgery can be less predictable in this condition due to the underlying muscle damage. So we've explored three distinct esophageal motility disorders: Achalasia, where the LOS is like a stubborn bouncer refusing to let anything pass; diffuse esophageal spasm, and hypercontractile esophagus, where the esophagus is either having a chaotic dance party or squeezing with superhuman strength, and scleroderma-related esophageal dysmotility, where the esophagus is caught in the crossfire of an autoimmune battle. Each of these conditions presents unique challenges, but the good news is we have a range of diagnostic tools and treatment options to help our patients. Let's recap the key takeaways. First, high-resolution manometry, or HRM, is our MVP when it comes to diagnosing these disorders. It gives us a detailed pressure map of the esophagus, allowing us to pinpoint the problem and classify the specific type of motility disorder. Next, the barium swallow, that classic radiological study, provides valuable visual clues. The bird beak, narrowing in achalasia, the potential corkscrew appearance in DOS, and the delayed clearance in scleroderma all help us confirm the diagnosis. And finally, upper GI endoscopy, with its ability to directly visualize the esophageal lining, helps us rule out other conditions, assess the extent of damage, and sometimes even guide treatment. Now, when it comes to management, the approach is tailored to the specific disorder. In achalasia, the focus is on reducing that stubborn LOS pressure. We have a variety of tools in our arsenal, from minimally invasive surgery like hilar myotomy to endoscopic techniques like pneumatic dilation and POEM. And for those who aren't candidates for these procedures, botulinum toxin injection or medications can provide temporary relief. For DOS and hypercontractile esophagus, the goal is to calm down that overactive esophagus and manage the symptoms. Lifestyle modifications, such as avoiding trigger foods and managing stress, are essential. Medications like calcium channel blockers, nitrates, and tricyclic antidepressants can help relax the muscles and ease the pain. And in some cases, botulinum toxin injection or even surgery might be considered. In scleroderma-related esophageal dysmotility, the focus shifts to controlling reflux and supporting the weakened esophagus. High-dose PPIs and prokinetic agents are crucial for managing reflux. Lifestyle changes, like elevating the head of the bed, can also help. And while surgery might be an option in some cases, the outcomes can be less predictable due to the underlying muscle damage. So there you have it, a comprehensive overview of esophageal motility disorders. But before we wrap up, I want to leave you with a thought-provoking question. Considering the complexities of these conditions and the limitations of current treatments, what advancements in diagnostics or treatment do you think will emerge in the future? Will we see more targeted therapies? Will artificial intelligence play a role in diagnosis and management? Will regenerative medicine offer hope for restoring esophageal function? Well, I'd love to hear your thoughts. Feel free to connect with me on LinkedIn and share your insights. Until then, keep cutting to the core. Before we sign off, I wanted to circle back to something we talked about earlier, the different types of achalasia. Remember those milkshake straw analogies? It's fascinating how each subtype responds differently to treatment. Type 2, with its panesophageal pressurization, often shows the best response to treatment. It's almost as if the esophagus is trying its best, but just can't quite coordinate those contractions. And this really highlights the importance of accurately diagnosing the specific subtype of achalasia, because it directly influences our treatment strategy. A one-size-fits-all approach simply won't do. And speaking of treatment, let's not forget the role of botulinum toxin. While it's often seen as a temporary fix, it can be a game changer for patients who are not suitable for more invasive procedures. Imagine being able to offer relief to someone who's been struggling to swallow, simply by injecting a substance that relaxes that overactive LOS muscle. It's really remarkable. Of course, botulinum toxin isn't a permanent solution. It wears off over time, requiring repeat injections. But for some patients, it can significantly improve their quality of life, allowing them to enjoy meals and regain a sense of normalcy. And as we look to the future, it's exciting to think about the potential for even more targeted and effective treatments for achalasia and other esophageal motility disorders. Perhaps we'll see advancements in gene therapy, targeting the specific neurons responsible for esophageal dysfunction. Or maybe we'll develop new medications that precisely modulate the nerves and muscles involved in swallowing. The possibilities are really endless, and I, for one, am eager to see what the future holds for this field. Thank you for joining me on this deep dive into the world of esophageal motility disorders. I hope you found it informative and insightful. If you have any questions or thoughts, please don't hesitate to connect with me on LinkedIn. Until then, keep cutting to the core.